Welcome back, everyone, to the deep dive, where we take a stack of research and try to make sense of it all.
That's right. Try to boil it down to the essentials.
Yeah, so you don't have to wade through it all yourselves. And today we're tackling a topic that's pretty much a daily reality for general practitioners out there:
Hmm.
depression in adults.
Yeah, it's something that every GP is going to be seeing this all the time, and we talk about it a lot. But we thought it would be helpful to kind of go beyond the
Yeah,
basics,
a little deeper dive
a deeper dive.
into
Exactly.
the latest guidelines and, what's new in terms of prevalence and diagnosis and really
Treatment, prognosis, the whole nine yards.
Yeah. So really thinking about how you can actually use this information in your practice every day.
Exactly. Give you some actionable insights.
So I think a good place to start might be just acknowledging the scope of this problem,
Yeah.
because it's easy to get caught up in like, okay, I've got a patient in front of me who's depressed, but
Right. The day to day.
yeah, what's the big picture here?
Yeah. It's easy to lose sight of just how widespread this really is.
And it is, I mean, the numbers are pretty staggering when you really look at it. We're talking about a lifetime prevalence of major depressive disorder,
MDD.
MDD,
Mm-hmm.
right around 11% in those high-income countries.
Mm-hmm.
But then you look at low- and middle-income countries, and it jumps up to 15%.
Yeah, and the World Health Organization estimates about 280 million people globally are dealing with this every year.
Uh,
So
yeah.
this is a massive issue.
Yeah, it's not just a small percentage of the population.
Yeah,
It's a significant portion. And it affects, not just those individuals, but their families,
of course.
their communities. It's a real public health.
Absolutely, a societal issue for
Right.
sure.
Yeah, so for GPs, I mean, this is something that you're going to be encountering all the time in your practice.
You're going to see this so often. So, getting that diagnosis right
Is key.
is absolutely key, and really understanding what those criteria are.
Yeah, because it's not just about, feeling a little bit sad or down.
Yeah.
It's
Right.
it's a whole cluster of symptoms that really have to be present.
And they have to be there for at least 2 weeks to really meet that threshold for a major depressive episode.
Okay, so DSM-5-TR, that's kind of our Bible here. What are some of the key things that we're looking for?
Okay, so, you mentioned depressed mood most of the day, nearly every day, right?
Right.
That's kind of the hallmark.
Yeah.
But there are a lot of more subtle things that we need to be paying attention to too, like diminished interest or pleasure
Like in things that they used to enjoy.
in things that they used to love, right? So it's not just, oh, I don't feel like going to that party tonight. It's, I used to love playing guitar and now I don't even want to pick it up.
Right, or spending time with friends, or things that really were important to them before.
Exactly. And this is persistent. It's not just a one-off, it's a pattern.
Right, and then there are those physical symptoms that sometimes get overlooked,
Oh, absolutely.
which I think it's fascinating because it really shows how intertwined the mind and body are.
Oh, for sure. Yeah.
So things like changes in appetite.
Significant changes. So either weight loss or weight gain,
Yeah.
sleep disturbances, so insomnia, or they're
Mhm.
sleeping too much, hypersomnia,
Yeah.
and even psychomotor agitation or retardation.
So that's like their movements and thoughts either speeding up or slowing down.
Exactly. So they might be really restless, or they might be moving very slowly, and their speech might be very slow, and their thinking might be slowed down.
So it's like their whole system is either revved up or kind of in slow motion,
Yeah, exactly. And then, of course, we have to think about the cognitive and emotional symptoms as well.
like fatigue,
Yeah, feeling really tired all the time, just like lack of energy.
feeling worthless or excessively guilty,
Yeah, those negative thoughts really start to take over.
and then problems concentrating or making decisions.
Right, and all of these things, you can imagine how much they can interfere with someone's ability to just function in their everyday life.
Yeah, absolutely. And then, of course, we can't forget about the possibility of recurrent thoughts of death or suicidal ideation.
Absolutely, that's a huge one.
That's a red flag we need to be assessing for that in every single patient.
Yeah, every patient who presents with these symptoms, we need to be asking about suicide.
And it's not enough to just rely on a screening tool.
Right, the PHQ-9 can be helpful,
Sure,
but it doesn't replace that direct conversation.
that human connection.
Exactly. We need to be creating that safe space where patients feel comfortable opening up to us about those really difficult thoughts.
Yeah, because sometimes they're not going to volunteer that information.
No.
So we have to ask.
We have to ask directly.
Yeah, and I think that's one of the challenges for GPs, in a busy primary care setting.
Yeah.
You might not always have a patient who comes in and says, I think I'm depressed.
Right. They might be there for something completely different.
Right. They might be complaining of fatigue or sleep problems or...
Right. They might not even connect the dots themselves.
Yeah. So it's up to us to kind of be detectives a little bit.
Exactly. Be that detective. Put those pieces together and think, could this be depression?
Even if it's not the primary reason for the visit.
Exactly. It's about having that high index of suspicion.
Yeah, so once we start to suspect depression, what are some of the tools that we can use to kind of confirm that diagnosis and assess the severity?
Well, there are some great screening tools out there.
Yeah.
The PHQ-2 is a really good one to start with.
Oh, 2 questions.
2 simple questions about interest and mood, and it's super quick.
Easy to integrate into a regular visit.
Exactly. So it's a good way to just kind of screen everyone, and then if they score positive on the PHQ-2, then we can move on to the PHQ-9.
Okay, so that's kind of like our first line of defense.
Exactly. And the PHQ-9 gives us a more in-depth assessment. It aligns really well with those DSM-5 criteria that we talked about.
Yeah.
And the nice thing about the PHQ-9 is that you can use it to track progress over time.
Oh, that's so helpful.
So we can see how patients are responding to treatment.
So it's not just a one-time thing. It's something we can use throughout their treatment journey.
Exactly.
Okay, so we've talked about diagnosis, but I think one of the things that can get really tricky in primary care is comorbidity. Oh, yeah? Because depression rarely exists in isolation.
It's very rare.
We've got patients with multiple conditions.
Yeah.
And it's hard to tease apart what's what.
It can be really challenging. You know, are we looking at symptoms of depression, or is this something else, or is it a combination of things?
Right. So what are some of the common comorbidities that we should be thinking about?
Well, anxiety disorders are huge.
Yeah.
PTSD is another one. OCD personality disorders, substance use disorders.
So many.
So many, yeah. So we really need to be thorough in our assessment.
And make sure that we're treating the right thing.
Exactly. We don't want to miss something.
Yeah, it's about seeing the whole picture.
The whole picture.
Not just the individual pieces. And I think one specific comorbidity that can be tricky is bipolar disorder.
Yes, especially bipolar 2. With those hypomanic episodes, they can be very subtle.
So easy to miss.
Easy to miss. And if we misdiagnose bipolar disorder as major depressive disorder, that can have real consequences for treatment.
So we need to be really paying attention to those subtle signs of elevated mood.
Yeah, increased energy, impulsivity, those kinds of things.
Yeah, those are the clues that might tell us, hey, this might be something more than just MDD.
Exactly.
And then, of course, we can't talk about depression without talking about suicide.
Right.
This is something that as GPs, we're in a unique position to really address.
We're on the front lines.
Yeah, so we need to be asking those difficult questions.
Yeah.
Assessing those risk factors and knowing when to intervene.
And remembering that suicidal thoughts can occur at any point.
Yeah.
It's not just in severe cases.
Right. So even if someone's depression seems mild, we still need to be having that conversation.
Absolutely.
And being vigilant throughout their treatment.
Exactly. And knowing when to refer to a specialist if needed.
Okay, so we've covered diagnoses. We've talked about these tricky comorbidities, suicide. But how do we actually start approaching treatment in a way that's going to be effective for our patients and really empower them?
Yeah, that's the million-dollar question, right?
Yeah. That's the big question. And it seems like even getting to that point of diagnosis, we've already covered so much.
Right. It is a lot to think about. But yeah, now comes the really important part, figuring out, okay, how are we actually going to help this person?
Exactly. So what are the kind of like foundational elements of depression treatment that every GP should have in their toolkit?
Well, I think you have to start with those 2 main pillars, pharmacotherapy and psychotherapy.
Okay, so medication and therapy.
Yeah, because the medication can really help address those underlying chemical imbalances, you know, the brain chemistry that's going awry in depression.
Yeah.
But therapy gives patients those tools and strategies to really manage their thoughts and feelings and behaviors. So it's a 2-pronged approach.
Yeah, a powerful combination.
Right.
And it sounds like they work together.
They absolutely do. In fact, for a lot of patients, a combination of both is going to be the most effective.
Makes sense. But before we get into the specifics of, which meds, which therapies, I want to circle back to something you said earlier about patient engagement.
Oh, yeah, that's crucial.
Because you can have the best treatment plan in the world.
Absolutely.
But if the patient's not on board,
it's not going to work.
Yeah. So how do we as GPs foster that engagement?
Well, I think it starts with education.
Okay.
Really explaining to patients what depression is and what it isn't.
Demystifying it a bit.
Demystifying it, exactly, because there's so much stigma still.
Right.
And so many misconceptions and fears about treatment.
Yeah, I think a lot of patients, they see it as a personal weakness.
Oh, absolutely.
Yeah.
Like something's wrong with me. I should be able to just snap out of this.
Right.
And so we need to really emphasize that it's a medical condition, just like any other medical condition.
Yeah, and I think talking about the brain chemistry,
Hmm.
mentioning those neurotransmitters like serotonin and norepinephrine
Right.
can be helpful because it makes it more concrete.
It does. It takes away that blame,
Yeah.
and it gives them a sense of, okay, this is something that we can target.
Yeah, so it's not your fault this is happening. It's something that we can address. Okay, so once we've kind of laid that groundwork, how do we actually start talking about treatment options?
Well, like we said, medication is often a cornerstone.
Mm.
And there's a whole range of antidepressants out there, SSRIs, SNRIs, TCAs, MAOIs.
Alphabet soup.
It's a lot to keep track of.
Right.
So, I think it's helpful to just kind of review those different classes, what their mechanisms of action are, what their side effects are.
So SSRIs, those are usually our first-line choice.
Yeah, generally well tolerated, good side effect profile.
And then SNRIs, those can be helpful for people who haven't responded to SSRIs or who have a lot of fatigue or pain along with
Oh,
their depression.
exactly. Yeah, they can be really effective for those patients.
Okay. And then we have the TCA's been around for a while.
Right. They're effective, but they do tend to have more side effects.
So we don't use them as much these days.
Not as much, but they still have their place.
Okay, and then MAOIs. Those are the ones with the dietary restrictions.
Right. So those are a little more complicated to manage.
Yeah, so how do we choose among all of these options? What are the factors that we should be considering?
Well, it really depends on the individual patient.
Yeah.
How severe is their depression? What's their past experience with antidepressants?
Their medical history.
Yeah. Any other medical conditions? They have any other medications they're taking?
And of course, their preferences.
Oh, absolutely. Some people are really sensitive to certain side effects.
Right.
So, we need to involve them in that decision-making process.
Shared decision-making.
Exactly. Help them choose a medication that feels right for them.
Yeah, it's not just us telling them what to do. It's a collaboration.
Absolutely.
Okay, so let's say we've chosen a medication. What happens next?
Close monitoring is key,
Okay,
especially in those first few weeks after starting an antidepressant.
so we're checking in with them regularly.
Yes, we need to see how they're responding. Are they
Yeah.
having any side effects? Are they having any thoughts of suicide?
Because those can sometimes emerge.
They can, and we also need to be really good about communicating with our patients, explaining that it might take some time to see the full effects of the medication.
Right, it's not an instant fix.
No, it can take a few weeks, and also that side effects often go away on their own.
So reassure them about that.
Right, and also that it's really important to take the medication as prescribed.
Even when they start feeling better.
Yes, because that's when people tend to stop taking it and then they relapse.
Yeah, adherence is such a challenge.
It's huge. I mean, people forget they get busy.
Side effects.
Yeah, side effects are a big one.
So what are some strategies that we can use to improve adherence?
Well, I think simplifying the dosing regimen can help.
Okay.
So if we can prescribe something once a day, that's usually easier for people to remember.
Yeah.
Clear instructions are really important too.
Both written and verbal.
Yes. Make sure they understand exactly how to take the medication.
And I think pill organizers can be really helpful.
Oh, for sure. Especially if they're taking multiple medications.
And then there's motivational interviewing.
Yeah, which is a great way to really understand what the patient's barriers are.
Yeah, not just lecturing them about taking their meds.
Right. It's about working with them to find solutions.
Okay, so we've talked about medication, but let's not forget about therapy.
Yes, psychotherapy is so important.
It feels like sometimes it gets overshadowed.
I think it does because medication is so tangible. It's easy to prescribe and it can provide relief fairly quickly.
Right.
But therapy really gets at those underlying issues.
The root of the problem.
Exactly. And it gives patients the skills they need to manage their depression long term.
So it's not just about symptom relief, it's about real change.
Right. It's about giving them the tools to cope with life's challenges.
So what are some of the different types of therapy that we should be familiar with?
Well, CBT is a big one, cognitive behavioral therapy.
Right, that's the one where we're trying to change those negative thought patterns.
Exactly. So it's about identifying those negative thoughts, challenging them, and replacing them with more helpful thoughts.
And learning coping skills.
Yes, practical strategies to manage stress and regulate emotions.
Okay, and then there's interpersonal therapy, or IPT.
Yeah, that focuses on relationships and social skills.
Okay, so if someone's depression is being triggered by relationship problems or they're having trouble connecting with people.
Exactly, then IPT can be really helpful.
And then there's psychodynamic therapy.
Right. which is a little more in-depth. It goes into past experiences and unresolved conflicts.
So trying to uncover those deeper patterns.
Yeah, it can be really insightful for some people.
And of course, mindfulness-based therapy is becoming more popular.
Yes, that's a great one for helping people stay present and focus on the here and now.
So many options.
There are a lot of options, and we can tailor the therapy to the individual patient's needs.
Yeah, so someone with social anxiety might benefit from CBT or IPT,
Right.
whereas someone with a history of trauma might benefit from psychodynamic therapy.
Exactly. It's about finding the right fit.
Now, of course, we're not therapists ourselves,
Right.
so we need to know when to refer.
Absolutely. We need to know our limits.
Yeah, and it's not a failure to refer.
No, it's about making sure the patient gets the best possible care.
Right, we're part of a team.
Exactly. And we can still provide a lot of support and guidance even if we're not the ones delivering the therapy.
Yeah, that's a really important point.
Yeah.
Okay, so what about when our initial treatment efforts don't work?
Treatment-resistant depression.
Yeah, they can be so frustrating.
It is for both the patient and the doctor.
So what do we do when we hit that wall?
Well, I think the first step is to reassess.
Okay.
Go back and make sure we've got the diagnosis right. Make sure we're not missing any comorbidities.
Double check everything.
Exactly. And make sure the patient's actually taking their medication as prescribed.
Adherence again.
It always comes back to adherence. And if everything checks out, then we can think about optimizing the treatment.
Okay, so that might mean adjusting the dose of the antidepressant.
Right. Or switching to a different medication.
And if that doesn't work,
Then we can start thinking about combining medications.
but that's probably something that we should refer to a psychiatrist for.
Yeah, it can get pretty complex.
Okay. So referral is always an option.
It is. And it doesn't mean that we've failed.
Right, it just means that the patient needs a higher level of care.
Exactly.
Okay. And then what about non-invasive treatments like TMS?
Oh, TMS is a great option for people who haven't responded to medication or who can't tolerate medication.
Yeah, I've heard good things about it.
Yeah, it's a really promising treatment.
Okay, so now I want to shift gears a little bit and talk about a specific population that has some unique needs: pregnant and postpartum women.
Yeah, perinatal depression.
That's a tough one.
It is. It's a really vulnerable time for women.
And there's so much stigma.
So much stigma.
Yeah, so it can be really hard for women to come forward and ask for help.
Absolutely. So I think routine mental health screening during pregnancy and postpartum care is really important.
Catch it early.
Exactly.
So how do we approach treatment in this population?
Well, a lot of the same principles apply, but we have to be extra cautious with medication,
Especially during pregnancy.
especially during pregnancy, because we have to think about the baby.
Right.
So for mild to moderate depression during pregnancy, psychotherapy is usually the first-line treatment.
Okay, so CBT can be really helpful.
Yeah, it can help women develop those coping skills without having to take medication.
And then if it's more severe or if therapy alone isn't enough,
Then we might need to consider medication, but that's a decision that should be made in consultation with a psychiatrist.
okay.
And we have to weigh the risks and benefits very carefully.
And there are some antidepressants that are considered safer than others during pregnancy.
Right. The SSRIs are generally the first-line choice.
Okay.
But even within the SSRIs, some are better than others.
So fluoxetine, sertraline, citalopram, those are the ones with the most data.
Exactly. Those are the ones we feel most comfortable with.
Okay. And then postpartum.
Postpartum, the same principles apply: careful assessment, shared decision-making.
Yeah.
And psychotherapy is still a great option.
And the range of medications that we can use is broader.
Yes, because we don't have to worry about the fetus anymore.
Right. But we do have to think about breastfeeding.
Yeah, if the woman is breastfeeding, then that will influence our medication choices.
Okay. So a lot of factors to consider.
It's a complex area.
And of course, if it's severe postpartum depression,
Right.
we might need to think about hospitalization.
Yes, if there's a risk to the mother or the baby, then we need to get them to a safe place where they can get intensive treatment.
Wow. Okay, so we've covered a lot of ground here.
Yeah.
You know, the core principles of treatment: medication management, psychotherapy, treatment-resistant depression, perinatal depression.
Yeah.
It's a lot.
It is. It's a lot to take in.
But I feel like we're starting to get a good grasp on how to approach depression in primary care.
Yeah, I think so. And remember, this is an ongoing learning process. You know, the field of mental health is always evolving.
Absolutely.
So we have to stay up to date.
Keep learning.
Keep learning.
You know, we've talked a lot about the clinical side of things. But I think what's really important to remember is that, you know, we're talking about real people here
Oh, absolutely.
with real struggles.
These are not just diagnoses. These are human beings.
Right. And that brings us to the whole topic of patient education and support.
That's so important.
Because I think When patients really understand what's going on with them,
Yeah.
it can make a huge difference.
It empowers them.
Yeah, and it can reduce that fear and stigma.
Oh, absolutely, because I think a lot of people, they they feel like depression is their fault.
Right. Like they should just be able to snap out of it.
Yeah, like it's a sign of weakness.
Yeah. And
Right.
so we need to really help them reframe that understanding.
Hmm.
Explain that it's a medical condition.
It's a real illness. It's not a personality flaw.
Yeah. And I think talking about the brain chemistry can be helpful.
Oh, yeah, it makes it more concrete,
Yeah, like, okay, this is something that's happening in my brain.
It's not just me.
It's not just me being weak or whatever.
Right, it's not your fault.
And that opens the door to talking about treatment in a more, I think, accepting way.
Yeah, because then they can see, okay, there are things we can do about this.
Yeah. So whether it's medication or therapy,
Hmm.
they're more likely to engage if they understand the why.
The why behind the what.
Exactly. And I think we should also talk about lifestyle modification.
Oh, yeah, lifestyle's huge.
Because we know that things like exercise and diet and sleep,
Stress management.
all of that can really impact mood.
Absolutely.
But I sometimes hesitate to bring those things up because I don't want to overwhelm patients.
I know what you mean. It can feel like piling on.
Yeah, but I think if we frame it in the right way,
Mm-hmm.
it can be empowering.
Exactly. It's not about giving them another to-do list.
Right.
It's about saying, okay, here are some things that you have some control over
Yeah,
that can actually make a difference in how you feel.
and it doesn't have to be perfect.
No,
Wow.
just small changes can make a big difference.
Yeah, and I think social support is
Uh-huh.
another really important piece of the puzzle
Oh, for sure.
because isolation can really fuel depression.
It can.
So connecting patients with support groups
Mm-hmm.
or encouraging them to reach out to family and friends.
Yeah, just having someone to talk to can be so helpful.
Yeah, and we as GPs can play a role in that.
Oh, absolutely. We can provide resources. We can offer encouragement.
Yeah, and I think that brings us to long-term management
Mm.
because it's not just about getting through that acute episode.
Right. It's about preventing relapse.
Yeah. So what does long-term management look like?
Well, continuing therapy, even after symptoms improve, can be really helpful
Okay.
because it helps solidify those coping skills and it gives them a chance to work through any underlying issues.
Yeah, it's like that ongoing maintenance
Exactly.
and regular check-ins with the GP
Yeah, even if it's just a brief visit.
just to make sure things are still on track.
Exactly. And then, of course, self-care is huge.
Yeah.
Encouraging patients to prioritize their well-being.
Engage in activities they enjoy.
Mindfulness, meditation, yoga, all of those things can help.
So it's really about shifting from a reactive approach
Yeah.
to a proactive approach.
Absolutely taking charge of your mental health.
Wow. Well, this has been an incredible deep dive.
It has. We've covered a lot.
So much information.
But I think the key takeaway is that, as GPs, we have such an important role to play.
In helping our patients with depression,
Yeah, we're often the first point of contact.
and we can make such a difference in their lives.
Absolutely. And, you don't have to have all the answers.
That's right.
It's okay to reach out for help if you need it.
Consult with colleagues.
Refer to specialists.
Yeah, we're all in this together.
We are.
So to all our listeners out there, thanks for joining us on this deep dive.
Yes, thank you.
We hope you found it helpful
Informative.
and maybe even a little bit inspiring.
Inspiring.
Until next time, keep learning, keep exploring, and keep diving deep.
See you next time.